about what we're doing at the moment with IMAS. I have been for years, and Marco will tell you that Marco, go off mute because I'd love to talk about this really quickly before we get going properly. But when we first met in 2016, I think it was, in Milan, and in the airport hotel, I think it was, and we were talking about what was then the Atlas project, which became EMAS, then became IMAS. I remember watching the program, watching you present some of the early data from your Atlas project and getting very excited about what it could mean for the way in which we were looking at about the insights we can get about people with axSpA. And as I came up with ideas of how we could use the data, the next slide, every single next slide was you showing me that thing that I had thought about, and it was so exciting. And to see that now that whole data set has now got bigger and bigger, and now, you know, it's covered Europe. We're now looking international, and getting that report together is just fabulous. Marco, I mean, can you remember that moment?
Yeah, yes, it was incredible, as you mentioned. So I think we were in Zurich. It was at the airport.
Zurich airport.
Yes, yes. Yeah. We met later in another meeting in Milan, as I remember. So it was interesting because for me it was the first time we provide information that was really gathered from the patient perspective. So me being a patient, and with the support of the SIADE, the Spanish Federation of Spondyloarthritis, we got for the first time, I think, the possibility not to really concentrate on aspects that matter to patients, aspects of life, spheres of life that were neglected by physicians or clinicians because they were not their targets. They were not. They didn't pay attention to aspects like, for example, the effort or the limitation tidying shoes, for example, no, in our daily life. So for me, it was incredible to connect with other patients like you that saw also that's value, no? Behind the at that time was the Atlas, no? Then became the, as you mentioned, the Europeans.
Yeah. And what's really exciting for me in this moment right now is that this year, I don't know if you all know, but this year, IMAS, IMAS was originally funded by and run by Novartis on our behalf, effectively. And now this year, all the IMAS data set has now come back to ASIF, and now we're running the project through us ourselves. And this is really exciting for me because one of the conversations that I had on a regular basis was, if Novartis are collecting the data, what are they doing with our data? And what this means is that we don't have to answer that question anymore. We now control the data. We're now playing with it. We can look at the insights from the patient perspective and really focus on that. And hopefully we can engage many more organizations with that in mind. So I'm looking forward to that, that freedom as well. And to say, while I say that, you know, the one thing I was really impressed by with Novartis is that the way in which Marco and I, when we were in conversations with them, they always allowed us complete freedom to do what we wanted anyway. It just means that the conversation has changed, not the outcome. So I would like to introduce the agenda now, if that's okay. Is there anything else, any of the housekeeping I need to cover off, Joe, that I've forgotten?
I don't think so, no.
I don't have to deal with emergency exits and fire alarms and that kind of thing, so that's good.
Hopefully not. I guess just to say that as we go through the presentations, we will take questions at the end of each presentation, but obviously if you think of something during a presentation, pop it in the chat, and we're keeping an eye on that between us. And hopefully you can see the agenda slide there, can you, on the screen?
Yep. I can see it. I presume everyone else can then. So what we're going to do is we're just going to go through, first of all, we're going to ask Joe to take us through, who's the the project manager for IMAS from ASIF, and tell us about the IMAS project and talk us through what's in the global report. Then we'll get Victoria Navarro-Compán to come on and talk to us. She's the ASAS Secretary and President-elect, and to give us a clinical perspective on the IMAS results. And then Maranda van Dam from South Africa to come on and talk about how those results are being used. I'm going to hand straight over to Joe and say, Joe, would you like to take us through some of the results in the global report?
Thank you, Raj. I would love to. I am just going to find my slides, hopefully. Okay. Can everybody see that on the screen? Yeah, perfect.
Yeah,
thank you. Good, thank you. So thanks, Raj. I'm really blown away by the number of people that are on the call. Actually, I've just been pressing my admit to the meeting button like quite a frenzy. So yeah, great to see you. Thank you for joining us. Thanks for your time. As Raj says, I'm going to talk a bit about our report, the Burden of Axial Spondyloarthritis, a Global Patient Perspective. That was published at the end of January, and I just want to take a bit of time to familiarise you with its content, and particularly with some of the most important IMAS results, and just talk a little bit about the rationale behind the report as well. So before we get into that report, I am conscious that we've got a few newish people to our community here and may not be so familiar with IMAS. So I'm just going to give not even 2 minutes, but just a brief overview of what IMAS is for those that don't know. So it is a research initiative to better understand the impact and burden of living with axSpA from the patient perspective. It's an online questionnaire, which is a very comprehensive questionnaire completed by people living with the disease to gain the patient perspective. It goes beyond the physical symptoms and seeks to establish a full picture of what life with axSpA is like, and we'll see more about that as we explore the results a little bit. It also includes a big driver behind it was to include focusing on and starting to understand what the unmet needs of people living with the disease are. And IMAS was started by Marco, as Raj said, because whilst there was growing clinical research, the patient perspective and experiences were really not well understood. And in particular, they were not understood by people who were responsible for management of the disease. The goal of IMAS is to therefore use that data in health policy and disease management, and in fact, by anybody who is involved with treatment of people with axSpA. So a little bit of an overview about the questionnaire itself. So it has over 120 questions, and they help us to comprehensively understand the lived experience of axSpA patients. And you can see here in the blue box the different areas that are covered by the survey. It uses validated patient-reported outcome measures to help us to quantify better things like disease activity and risk of psychological harm. In particular, we use the BASDI, the Bath Ankylosing Spondylitis Disease Activity Index, which is a commonly used validated patient-reported outcome scale, and that helps us to understand levels of disease activity. So just because we are going to talk about that a little bit in the presentation, the 6 questions are about pain, swelling, stiffness and discomfort, and they're answered. You can see a copy of the outcome measure there. The questions are answered and totaled out of 10, and the higher the score, the more severe the disease activity is indicated by that score. And generally, we consider an overall score in the BASDI of 4 or more to indicate higher disease activity and suboptimally controlled disease. So just moving on to the report, we have 6 chapters, the first providing a short explanation of axSpA and the IMAS project. Chapters 2 through 5 capture the far-reaching impacts of living with axSpA and demonstrate how many of the challenges are linked and cannot be viewed as a standalone issue. And we'll talk a little bit more about that in the coming slides. And then chapter 6 discusses healthcare utilisation and treatments, with the rationale of demonstrating that axSpA, especially when it's not well controlled, impacts healthcare systems as well as individuals. We're delighted that Dr. Xenophon Baraliakos, President of ASAS, wrote the report forward. Many of you will know Xenophon and ASAS, but and Victoria is going to be the next president of ASAS. She's up next, and they are the organisation, for those of you that don't know, who are pretty much responsible for driving axSpA research globally. We also have 9 calls to action for healthcare professionals and policymakers, and each of the chapters summarises the key messages within it at the outset. So those that haven't got the time to read the full report can get those key messages up front in each chapter. So in the first report chapter, we spend some time describing what axial spondyloarthritis is, including the main symptoms, challenges and the prevalence. And then there's also some background on the IMAS study and on the methods used within it. And there we can see the 27 countries where people completed the survey, and the numbers in brackets are the number of people that completed the survey from each of those countries. And within the report, we highlight any regional differences and any notable gender differences within each of the chapters. So chapter 2 explores the axSpA diagnosis, including the time from onset of symptoms to diagnosis, the healthcare providers seen prior to diagnosis, the healthcare provider that diagnosed the disease in the end, and the correlation between diagnostic delay and poorer physical outcomes. So IMAS reveals an unacceptable average global diagnostic delay of 7.4 years. Which is even worse if you're a female, by an average of approximately 2 years. Perhaps the main message in this chapter, for me anyway, is the damage done by delayed diagnosis. So the links between poorer disease, physical health outcomes linked to the longer delay. So in this table here, the first table on the left, we can see the spinal stiffness measure is particularly illuminating, where respondents reporting no restriction have an average delay of 3.7 years, and those with severe restriction report an average of 9.1 years. I think that's a pretty startling correlation, or at least an association between those figures. And we can also see that the average delay differs quite significantly by region, with South Africa and North America faring the worst. But I would question, even in Asia, with the lowest average, whether 4.2 years is actually an acceptable time to wait to be diagnosed. And I think we all agree that it's clearly not. And finally, in this chapter, we've got a table there that shows the regional differences in the specialty diagnosing the disease. And then we move on to the physical health chapter. And this focuses particularly on the disease activity levels and physical comorbidities. So as I said a bit earlier, we use the BASDAI to measure disease activity, and above 4 is that threshold to indicate high disease activity. So one of the key messages for me from this chapter is that 75% of respondents reported that their axSpA was in that range above 4, so in the range of suboptimally controlled disease. There are also regional differences, as we can see, but even the lowest regional average in Asia is above the threshold for well-controlled disease, or for lower disease activity. We can see from the BASDAI categories that the most troublesome areas for people that responded to the survey are fatigue, pain in the neck, back and hips, and stiffness. And we also report that higher disease activity is associated with having higher number of comorbidities. The average number of comorbidities is 1.4 for people with a BASDAI under 4, so lower disease activity, compared to 2.4 for poorly controlled disease. And we can also look at the number and range of comorbidities reported. So there we have a total of 27 different physical comorbidities. And this range of comorbidities, including extra-articular manifestations of axSpA, helped to prompt our call to action about the provision of multidisciplinary care. And then we have a mental health chapter. So you may have noticed from the previous slide that the top 3 comorbidities were actually psychological comorbidities rather than physical ones. And we can see here that sleep disorders, anxiety and depression were reported at approximately 43, 40 and 37% respectively. They're really, really high numbers. Using the GHQ-12 to assess the presence of psychological distress, we also see that just under 60% of respondents indicated that they are at risk of psychological distress. And yet we can also see that 66% of respondents had not visited a psychologist or psychiatrist in the previous 12 months. Now, to me, this clearly shows a serious unmet need in accessing mental health support. And then we can look at the regional differences again in the GHQ-12 scores, with South Africa again being the worst affected. However, I would say again that even the regions with the lower average scores still hit that threshold for risk of psychological distress.
Joe, before you skip on, the one thing that's occurring to me is I should have flagged it up front, is as we're looking at this report, so we're looking at the data here, I'd love everyone to be really thinking about what it means for them and their organisations and in their regions. And as you're looking at it and you're seeing things which may stand out for you, to make a note of it, because at the end of this, we can have a discussion, and I'd love to be able to, to try to tease out some of those things that you're thinking now. When we get to that point in the conversation. I mean, there's lots of things I'm writing down right now, so it'd be really good to hear some of your thoughts too. Sorry, Joe.
Yeah, no problem at all.
I see Marco's put his hand up as well, so just really quickly go to Marco.
Yep.
No, I can wait. So Joe, go ahead, and I can make my comment after. So don't worry.
Okay, brilliant.
Okay.
Marco.
Okay, great. Thank you. And then the final chapter, I guess, about the impacts on individuals and broader society is the socioeconomic impacts chapter. The IMAS report paints a clear picture of the wider socioeconomic difficulties experienced by people living with axSpA. So respondents to the survey indicated that they were restricted in many daily activities, with over half of respondents reporting medium or high levels of restriction in doing housework, walking down the stairs, or getting up from bed. Over a third reported high or medium levels of difficulty in driving or using public transport, and 1/3 finding at least moderate difficulty with certain elements of self-care. Working life's also a significant challenge for many respondents. 46% said their job choice was influenced by the disease, and a huge 71% said that they'd actually had difficulties finding a job due to axSpA. And then an enormous 20% of people, this isn't a table on the slide, but it is in the key messages. 20% of people also reported being on sick leave at the time they took the survey, with 12% of those reporting permanent sick leave. IMAS also shows us the impact of axSpA on personal relationships, with 45% reporting worse or much worse relationships with colleagues than before the onset of the symptoms. And we can also see, sadly, that the relationships with family members and friends also tended to deteriorate. And then the final main chapter of the report is about healthcare system utilisation and the types of treatments that people have accessed. So the survey indicates a very clear link between increased healthcare utilisation and higher disease activity. Again, for me, this is one of the most important points in the whole report. So we can see this first table on the left, the average HCP visits by disease activity, that there are significantly increased average number of visits to almost all types of healthcare professionals when disease activity is suboptimally controlled. So there, the figures in the BAS diet are equal to or above 4 column. For example, visits to a primary care doctor almost double when disease activity is high. And you can see that almost all of them are significantly higher. Interestingly, the rheumatologist, the difference in visiting a rheumatologist is the least, and I guess we can understand that a little bit. There are also regional differences in the treatment of axSpA, with the specialist responsible for managing the condition varying significantly between regions. And we also see gender differences in accessing healthcare, with females being approximately twice as likely to see a physiotherapist or mental health professional. And so a few conclusions that I draw from all of this. We can see from the IMAS results in the global report that axSpA has far-reaching impacts into most areas of life, and we have to find a way to communicate the urgent need for change to policymakers and healthcare professionals who are involved in the care of people with the disease. One of the things that jumps out for me, and this little chart here, this little graphic here, is not anything that Marco's done or that has been analysed specifically. But when I'm reading the report, it just strikes me that all of these things are linked together, and one thing has a consequence for another thing. And it's just the way that all of these measures and statistics are linked. And so I just wanted to put that down to just show the few things that I've talked about, which is a very small amount of the IMAS results, and how interconnected they are and how complex this disease is and how people are living with it. Many of the issues discussed in the report are likely to have bidirectional in terms of, or be bidirectional in terms of cause and impact. And I've just tried to demonstrate that, as I say, a little bit. And finally, I'll want to talk to you about the calls to action. And these were developed, these 9 calls to action were developed to urge policymakers and healthcare professionals to make improvements of the care of people living with axSpA. They've been developed based on the evidence gathered through IMAS, and they complement ASAS EULAR International axSpA Management Guidelines, which set out the principles and recommendations to support best possible care and disease outcomes. So you've got an overview of each of the calls to action there, and I'll just quickly embellish those a little bit so that you understand the full wording. So the first call to action is to undertake a country level assessment, working with patient groups and clinical experts, using the IMAS data to better understand the needs of people living with the disease, and then to use that information to identify measurable actions to address the key challenges. And then we come to prioritise early and accurate axSpA diagnosis through reliable referral systems that promptly transition patients from primary care to an appropriate specialist, which will ideally be a rheumatologist, with the aim of avoiding delays in diagnosis. And then actively promote multidisciplinary care coordinated by an appropriate specialist and supported by relevant physical and mental health specialists. Work with employers and patient groups to define solutions that enable people with axSpA to access and remain part of the workforce. And then the healthcare professionals calls to actions. We have educate primary healthcare professionals to recognise the signs and symptoms of axSpA and to facilitate appropriate and timely referrals. And then increase awareness and recognition of the signs and symptoms amongst all healthcare providers that might see undiagnosed people with symptoms. So this particularly includes physiotherapists or orthopaedic doctors, where patients may go without knowing that they have axSpA, and then any specialists that typically treat the extra-articular manifestations, such as ophthalmologists, dermatologists, gastroenterologists. We want to ensure that people with axSpA have co-developed individually tailored care plans, and that they are regularly reviewed and that they're coordinated by an appropriate specialist. And we want to tailor those individual care plans to maximise long-term quality of life, recognising an individual's goals, their physical, psychological and socio-economic needs. And then finally, deliver education and training for healthcare professionals that help to identify patients requiring specific mental health support, so that we can ensure access to appropriate mental health care is available when it's needed. So that's my presentation. I hope that's helped to familiarise you with the some of the key messages, some of the key results from IMAS, and also the report and how we hope people will be able to use it. I'm going to now stop sharing my screen so I can see everybody properly.
Thanks, Jo. I mean, it's brilliant. Does anyone want to stick their hand up and ask a question? I know Marco wants to say something. Do you want to go first, Marco, or do you want to wait for other people to talk first?
Can I just very quickly say something? Yeah. Sorry to Marco. What I didn't say in that presentation as well is that there are a number of people on the webinar today that have helped us to develop the report, including Victoria and Fernando, and I just want to say a huge thank you for your input and steer and expertise. Sorry, Marco, please.
Yes, no, so really I'm impressed by this very brief but very concrete presentation of the data that help us for those who were involved since the beginning, and for the other who has been working for many years, and also for the new members or for the new colleagues who has joined recently. I would like only to mention, for example, the importance of the mental comorbidities, because I think this project, Atlas, IMAS, or IMAS, has been an important milestone for the scientific community, but also for the patients, for the patient too. Because, for example, in the specific case of mental disorders, I remember going to the studies where the prevalence of anxiety or depression or other mental comorbidity were really low. When we knew as a patient and as a scientist, we knew that it was no, this data didn't represent the reality of living with the disease. So the IMAS put or show for the first time the importance and highlight something that was neglected or were covered by clinicians, because they were more focused on the functional limitation or the disease activity or the response to the treatment, things that were important for rheumatologists in general. So I think that that's something which I wanted to highlight, because as Joe presented, the most important comorbidities were sleep disorder, anxiety, and depression. And I think this is something to consider, because it's a response of the functional loss and the physical disease and the burden of disease. So,
thank you, Marco. Can I saw that Nadia had a hand up, and then Fernando. So Nadia, do you want to?
Yeah, about the mental health comorbidities, I need to make a comment that we actually do know. I've been participating in some WHO consultations regarding non-communicable diseases and mental health issues. So axSpA is in the non-communicable diseases, is in there. So we actually do know that there is a lot of undiagnosed mental health comorbidities also. And we do know that there is a lot of delay in axSpA diagnosis, and there is a lot of untreated or unmentioned or in the category symptoms of people having some symptoms of depression or anxiety or PTSD due to their chronic pain or fatigue that they are not mentioning, or that they are not fitting the criteria of like standardized like DSM criteria to get a diagnosis of depression, but they do live with some type of anxiety or depression. So if they don't have a diagnosis, if they don't have the resources or somewhere to go to, so they are living with all the symptoms, they do have the burden of the disease, no resources or support. So it's a whole like another chapter, and it's a big issue, and it's in the front. Everybody's discussing. It's a hot topic everywhere, but we do need to do something about that. And a final comment, just quickly. I'm still wondering, because the new core outcome sets about pain involve psychological well-being and psychological aspects. Maybe do we maybe need to involve psychological aspects also in the core outcome sets of axSpA also? I'm like putting a question mark here, because we don't actually, I think we don't have the psychological aspect in the core outcome sets for axSpA. So maybe we do need them.
I'm loving as you ask the question, Nadia. I know you're not looking for a response, but I'm loving the fact that you're asking the question, and I can see Victoria nodding very gently in the background.
I'm just putting it out there because I know we are among people that we do have rheumatologists in the group. We do have people that work with axSpA patients. So maybe probably we need to consider it, because patient-reported outcomes need to have the psychological aspect. We need to measure closely, and it's very important also. So it's an issue. We have to be able to some way like measure and be careful about that too. So just a comment.
Nadia, thank you so much for the comments. I also want to say thank you very quickly before we go to Fernando, to Joe Edison for his large comment in the chat. I completely agree how beneficial the work is, and yes, all of those things you've said there. And Fernando.
Yes, I think that the biggest issue, the biggest problem continue to be the diagnostic delay. We have a new treatment, we have new ways to diagnose the patient, but the diagnostic delay continue to be the biggest problem, and we can see in the data.
Yeah, yes, I think that as a root cause to many other things, I think the diagnostic delay is a big thing. Annie, I saw your hand go up and go down again. Did you want to say something, or did you think twice about saying something?
I'm sorry, I hit the wrong button twice.
Okay.
Yes, I did. Thank you very much for the opportunity. I just wanted to confirm a lot of what Joe has put in the chat, because I was going to comment on pain and pain management, and the impact on the work environment is particularly strong in this country, and also the psychological impact of fatigue, anxiety and depression impacting the work environment, and people being able to deal with flares, being recognised for having a flare and how they manage it is really prevalent and really a major issue. So thank you very much. Thank you, Marco. Thank you.
And thank you, Annie. Dale, I can see you've got your hand up.
Thanks, Raj. Joe, thanks for the presentation. For me, what I love about IMAS, I think its strength is in the breadth of the data that we have. And I actually think your 4 recommendations, the 4 key ones for me, are absolutely the right ones. Early diagnostic, reductions in diagnostic delay, a clear sense of what high quality MDT care looks like, mental health, a massive issue, and also employment. And just in my country, for example, there's a new policy coming out whereby rheumatology teams will have embedded within them employment advisors for the first time. And I think that's a really welcome development. I guess I want to echo earlier comments about how those things, I'm sure, will shape what ASIF does, but the importance of having diagnostic delay at the absolute heart of everything, because everything follows if we get that part of the pathway right. And I want to share with you just briefly some work that NASA's been doing recently in Belfast in Northern Ireland. Our argument has been, if you want to seriously accelerate reductions in diagnostic delay, you've got to do everything on the patient pathway simultaneously. Public awareness, early presentation in primary care, referral pathway, early presentation in rheumatology. And we've just done a pilot there working with our clinical colleagues, where we've had a public awareness campaign which talks about lower back pain, not axSpA, which means nothing to most people, which gets them onto our online symptom checker. Meanwhile, our GP colleagues have been training primary care physicians to understand patients when they walk through the door not have axSpA, and we have a brand new axSpA clinic in place. And through a 6-week campaign, we reached just short of 1 million people. And we've had more than 300 people already have accessed our symptom checker, of whom 73% met the referral criteria, and will now chart their progress onwards. And we've been educating GPs, and we hope we'll have some data soon, which will show whether that, if you like, high dosage intervention has actually reduced diagnostic delay. We think it will. We think the logic is sound of doing all of that. But the more that we can amplify what's in the IMAS report around diagnostic delay and share our interventions that are trying to tackle that in various ways, the better, I think, for all of us. Thanks, Raj.
Thank you, Dale. Loris, I can see you have your hand up too.
Yes, I wanted to add a little bit more about the early diagnosis, but that is just half of the problem, because we also need to have access to innovation and in medical treatments, because you can have a diagnosis, but if you don't have access to the medication or the proper guidance, it will be just half of the way. I mean, yes, I know I have ASPA or any rheumatic disease, but then what else?
Brilliant. Thank you, Loris. I can't see any more questions or comments coming through at the moment, so I'm going to suggest that we move on to Victoria. While Victoria's loading up her presentation, for those of us with axSpA, if you want to get up, have a little stretch, don't worry, you're amongst friends and the cameras will, you can stay on while you have a little stretch. I'm still going to have a stretch now, but let's move on to Victoria.
Okay. Good morning. Well, I didn't introduce myself, but I'm Victoria Navarro-Compán. I work as a rheumatologist in Madrid. I'm actually now the Executive Secretary for ASAS, and it is my pleasure to be here, but I will say that my real pleasure is to be here because I've been growing what I call a story of success, which is this project. I mean, I was not at the beginning of the project. That was the idea of CIADE, led by Marco. But I remember also when I met Marco the first time for this project, and it was here in a hotel in Madrid. And I was during my second maternity leave, so that's why I remember exactly when it was, the age of my child. And that was a bit longer than 7 years ago. And I've seen growing all these projects since the Atlas to the IMAS and then to the IMAS. And I'm really amazed anytime I'm in a meeting of the project, because I can say that at least for myself, I've learned a lot how collaboration can lead a project to the success much farther than any other thing that we can do. Here in Spain, I remember we already went at that point to the media. We had meetings with the regional government representative, which if you ask as the head of the department, as a physician, to meet all these representatives from the government, that's usually not possible. So I think that this is the way why the project is also being such a success, because it has been done in a completely different manner. So I think that right now we are at the middle, but we'll see how we will move in the next step, because this is the success for the first part, but then we need to get into the implementation and to make use to solve those unmet needs that we have identified. So I think that with all the now you can see my screen, I assume. And if you cannot see, please stop me. Don't let me go through.
We can see, Victoria, we can see your team's meeting. We can't see the slides.
No? Okay, so I will stop sharing. So you cannot see it? No.
Not the slides, no.
Okay, I'll try to share. And we have tested this, I can tell you. So I just, okay.
If when you click share, if you look a little bit further down, yeah, there you go. Perfect.
No? Okay, so it was just probably too much time. So for me, I mean, I'm going to present from the clinical perspective, which is the potential relevance of the IMAS to improve care of patients with axial spondyloarthritis. But I think that we have mainly seen many of the topics that I will raise here, so I'll try to be brief. Well, we have seen from the report, a summary from Joe, how axial spondyloarthritis is a disease with a high burden, not only physical, which we have seen in many studies, but also now, because we have that perspective, which is different from other studies, we have identified also that there is a high burden of the disease in mental health, in socioeconomic aspect, and also in relationship to the utilization of the healthcare system. And it is important that we identify how to assess this and in the clinical setting. And therefore, it is also important to develop the appropriate instruments to assess each of these aspects, which that may be the reason why probably this was not already included in the course set. That was I did not answer at that moment because I knew I was going to present here. And we need to work further on how to assess this better and to provide some specific numbers. We know that the disease affects young people, so it's not only a matter of having a high burden, it is also a matter that it is affecting people in an age in which it is a very demanding age. And at this age, people are very productive in family, at work, and in social life. And that is why I think this is even more relevant than any other disease which affects different age. What do we have? We have that we have discussed about the diagnostic delay. And we know that according to the ASAS quality standards that were developed recently, in total, since the patient will start with the first symptom of the disease until the patient will have all the examinations performed and the diagnosis from the physician, it should take no longer than 3 months. However, we know that the situation from the IMAS refers us that it is nowadays there is a big difference between the ASAS quality and standards and what is occurring in clinical practice. What is occurring in reality? In reality, we are seeing a mean diagnostic delay of 7 years, according to the IMAS, and people can say this is of patients who have been diagnosed long time ago, but we have seen this also in patients who have been recently diagnosed. So we have here, I would say, the main issue, as has been discussed. If the patient is not diagnosed, anything further that we will develop in the future will not be possible to implement. So I would say that the main focus and the main effort that we will need to use the data from the IMAS report to claim could be in trying to improve the main unmet need nowadays, which is this diagnostic delay. We know that most patients are diagnosed by rheumatologists, but this depends on the regions, and we can also use the data from the IMAS because this is we can see the differences between the different regions. And here we see that in most countries and in most regions, the rheumatologist is the one performing the diagnosis. But for example, in Asia, this is also done frequently by orthopedic specialists, but in the rest of the regions, this is mainly by rheumatologists. So which is the problem here? Well, the problem is that before reaching the rheumatologist, usually patients visit other healthcare providers. And this includes the orthopedic, the primary care physician, the physiotherapist, and others. So what do we need to do here? If we want to improve this situation, we need to increase the awareness, and that's why we can use the data from the IMAS to increase the awareness of all those healthcare professionals who are visiting patients before reaching the rheumatology departments. And these are the gastroenterologist, the ophthalmologist, the GP, dermatologist, but also the physiotherapy and chiropractors. And mainly the orthopedics, I would say this depends on the setting, but I will say that these are the primary specialists on top of the primary physicians that visit patients with suspected axial spondyloarthritis. However, do we need to increase the awareness only for physicians? No, we need to increase the awareness also for the general population. As we have heard, axial spondyloarthritis for general population means nothing. They are not aware, and we should work also into increasing the awareness of the general population. Why is axial spondyloarthritis, why does it take longer to diagnose compared to other rheumatic diseases? Well, there are many reasons, but one of them is that For other rheumatic diseases, they usually affect peripheral joints. Rheumatoid arthritis or gout, for example, they affect a knee, they affect the hands or the toes, and that is visible for patients and also for physicians. However, the inflammation that it is occurring in the back is not shown outside, neither for the physician nor for the patient. So all what we get is just a symptom, which is back pain. And as we know, this is the first symptom in the majority of patients who initiate the disease. And what is the next issue here? What the next problem is that back pain is the main reason of consultation for musculoskeletal manifestations to physicians. So there is really an epidemic of back pain, while only 5% of those patients with chronic back pain have axial spondyloarthritis. And therefore, it is important that primary care physicians are able to identify which of those patients are more likely or have more chances to have an axial spondyloarthritis. But indeed, this is something which is difficult because we are saying that we cannot refer all patients with chronic back pain to the rheumatologist, but we need some tips and that will make the primary physician to at least get an alarm or which are the symptoms that should be referred. In addition, we need to provide access to rheumatologists because we know that this is not so easy nowadays. This depends on the regions, but I would say that in some countries, the first visit to rheumatologists may take approximately between 6 months or even longer. And why is this occurring? Well, rheumatology is not, one of the traditional specialties. And in this field, I will say it is one of or the only field in which usually the population is referred first to the surgeons and then to the doctor. We cannot imagine how patients will be referred because of having abdominal pain first to a surgeon than a gastroenterologist, but this is occurring in musculoskeletal diseases. And why? Well, mainly also because of the ratio of orthopedic surgeons compared to rheumatologists in general is much higher for the orthopedic surgeon than for rheumatologists, and therefore it is difficult to provide access to all the population. In addition, it is also important to increase awareness among the population. Why? Because even if we go to private practice, patients select orthopedic surgeons as the physician to consult if they have chronic back pain. Why is this occurring? Probably because of a lack of knowledge of what is a rheumatologist and what is an orthopedics. This is something that if you ask the population in general, what is a rheumatologist or what do they take care of? They think about old people. They don't ever think about children or they don't think about young people. So we need to work on this also with the population. And nowadays, I will say that we have an opportunity because social media are able to reach all the population, and it is a matter of implementing the best strategy to disseminate what is a rheumatologist, what is an orthopedic, and what is a chronic back pain that should be referred to the rheumatologist. In addition, it's not only back pain, what axial spondyloarthritis, as you all know, is showing as the manifestation, but there are mainly two other manifestations of the disease. One of them what are called peripheral manifestations, and these include arthritis in peripheral joints such as knees, hands, or feet, enthesitis, and dactylitis, which is the suchet digit. And then we also have extramusculoskeletal manifestation of the disease, which are uveitis, inflammatory bowel disease such as Crohn's disease or ulcerative colitis, and psoriasis. And I would like to highlight here that these extramusculoskeletal manifestations are not comorbidities of the disease. They are just manifestations of the disease, and that is how, in general, we should try to report. Why? Because the comorbidities are something different. Comorbidities are those diseases that are concomitant to axial spondyloarthritis, but that can also appear in other patients. And here we can see how on top of the manifestation of the disease, according to the IMAS, patients have other diseases and comorbidities that should be considered, especially depression, anxiety, fibromyalgia, osteoporosis, diabetes, and cardiovascular diseases. So in general, what we need to do is to collaborate and keep this collaboration with other specialists. And within these specialists, we need to collaborate with those who are visiting the extramusculoskeletal manifestation, who in a small group of patients start before the back pain, such as the ophthalmologist for the uveitis, the gastroenterologist for the inflammatory bowel disease, and the dermatologist for the psoriasis. And we also need to collaborate with orthopedic surgeons and with physiotherapists. And here I must admit that as friends, I have very good friends who are orthopedic surgeons, but sometimes also we need to put in value the effort and whether this is worse or not, depending on the setting. We have attempted several times to increase the awareness of the orthopedic surgeons, but in general, they are surgeons. Their mind is not such aware as a clinician. So for chronic back pain, they mainly think about degenerative diseases, and it is important that we create collaboration and program with orthopedic surgeons. And then with physiotherapists. Physiotherapists, I would say that nowadays most patients with chronic back pain go to physiotherapists, either referred by the GP if that is covered by the healthcare system, or in a private setting. And what we know is that in general, physiotherapists, and there are not so much data about their awareness of axial spondyloarthritis, but we have here a survey from UK in which the physiotherapists specialized in musculoskeletal disease were surveyed about their knowledge and about the degree of confidence about axial spondyloarthritis. And then there was a training and there were survey again. Here, it was a project that it was a good idea to collaborate, but what it reflects was that physiotherapists in general were not really aware of those symptoms and signs of axial spondyloarthritis, but controversial for this, they had a high level of confidence, thinking that they could know what was the disease about and the symptoms. So here we also have another target that, based on the data from the IMAS, we know that it is important to address and to collaborate with these health care professionals, in which sometimes we do not have so many relationships, rheumatologists ourselves, and therefore maybe it's important to develop new strategies to reach these healthcare professionals. And finally, after patients with suspected axial spondyloarthritis achieve rheumatology department, we also need tools to diagnose. We know that there is no gold standard to diagnose the disease. We know that this is more like a combination of sign, symptom, lab tests, and imaging. But we know that nowadays the imaging, and especially the MRI, it is one of the main tools to diagnose patients in an early stage of the disease. So it is important that we have access to these tools and that we also have the appropriate physician or radiologist informing the MRI. And for this, we need to keep working in how to improve the interpretation and of this diagnostic text in general, not only of the imaging, but also on the lab test. So finally, what is the IMAS providing us? Well, it is a great opportunity. It is what I would call an order book to claim which are the unmet needs nowadays for axial spondyloarthritis, especially for a timely diagnosis. And with this, we need to focus on education and training. We need to focus on accessibility to rheumatologists and also on the access to diagnosis workup tools. And here I did not mention, I focus on the unmet need for clinical practice, but obviously we know that the IMAS is also a great source of data for answering many of the research questions that we still have to answer in the field of axial spondyloarthritis. But I wanted to focus mainly on what was the plan of action that I think it could be implemented in clinical practice using the IMAS report. And with this, I think that I can stop sharing my screen so we can see again each other.
Victoria, thank you so much. That was absolutely fascinating. There are so many little bits in that I'd love to pick up on, and maybe we'll pick up on during the discussion section. I can see that Dale has got his hand up, so I'd love to go straight to Dale to ask his question. Dale.
Yeah, Victoria, thank you. Really, really good presentation. And I echo all of your points generally about increasing awareness amongst health professionals. And the study you cite about physiotherapist knowledge being far less than we would like it to be is really sobering. So I want to ask you a question about undergraduate curriculum with regard to rheumatology. Let me just set some context. So we're in conversations right now with the British Society of Rheumatology. And our idea is to create a standardized undergraduate rheumatology curriculum and offer that to every single medical school in the UK. And then simultaneously look at the curriculum requirements of the range of allied health professionals and try and construct a Venn diagram and figure out what should be the core components and which of them are specialty specific. So I wondered, has ASAS done any work to try and map out curriculum requirements at undergraduate level for the range of specialties?
I don't think there is a specific, I mean, within ASAS, there is no specific program. I think that this is more in EULAR, and probably I think Ramiro was more involved in this. But I think there is more like trying to homogenize the education program, not only for the training of rheumatology, but also for the undergraduate. The issue I see with the undergraduate education is that rheumatologists so far in the university do not have a strength role. This is improving, but in general, this is mainly in the hands of internists. And also that sometimes when you study something in the career and you have never seen it in practice, then you forget for the rest of your life. I think that all of us in rheumatologists have studied, well, in that day it was ankylosing spondylitis, and nowadays axial spondyloarthritis. But if you don't see a patient, sometimes it's hard to remember what is really happening and for the future.
Thank you, Victoria. I'm going to invite anybody else who's got any questions to hold on to those thoughts so that we can go on to Miranda's presentation on using IMAS evidence in South Africa, and what has been. Dieter, is it okay if we hold your thought, or would you like to just throw it in now?
Yeah, perhaps I could add this now, I think.
Okay.
I was a little late, so sorry, I do not know whether this was covered. I fully support all what was said. There's one point, I think, if a patient is diagnosed with axSpA, for example, then he needs self-management, he needs training from the beginning. And this is what we should demand as well, because the patient, to my mind, is responsible for his outcome. And he should know what kind of, let's say, what the health system offers, what is there to support him or her. So this is, to my mind, essential, and we should also not forget that point.
Got it. Dieter, thank you very much. That's a good point to raise. What we might do is come back onto that when we come to the discussion section about where maybe what different countries are doing in respect to that as well, to see whether there's any established protocols there. But thank you very much, Dieter. I can see Miranda's already got her slides up, so we're going to move on to Miranda.
Thank you so much, and thank you for the opportunity to chat to you about what happened in South Africa with IMAS. And I guess the question for us is if research in developing countries is worthwhile. Or should not a developing country rather be focusing on other tasks and leave the research for more developing countries? What do we know about axSpA and research in South Africa? Well, I think we all know the stats of the 62 million population and the 85 rheumatologists. Those are statistics we are all familiar with. But what does that tell us about the axSpA patient? Not a lot. If we look back into the history of South Africa and we comb all the Google archives, we can find one study only done in 2015 with 27 patients across Africa. And that speaks chapters of a massive gap of evidence in South Africa. So of course, when the opportunity presented itself to be able to collect data in our country with patient evidence, we took that opportunity up with both hands. Because patient advocacy in the R&D space in South Africa is definitely a novel idea. I'll never forget when we presented the first IMAS data to produce a manuscript to our physicians, and Marco was in that meeting, is that one of the physicians were completely shocked, a rheumatologist, by the delay in diagnosis in our country. And we could clearly see that this was news for them as well. Next slide, please. So the launch of IMAS and our organization almost happened at exactly the same time, which means that we formalized our organization almost at the same time as the opportunity came up for us to present IMAS, which it's a bit like discovering a dinosaur bones in your back garden, you know. Everybody believes that there are dinosaurs in South Africa, but nobody would actually really believe it unless we discovered some bones. And the IMAS survey amplified these efforts of ours. And this survey would finally be these bones that we collected in South Africa to show our community and our government that this disease is real and this is how it is affecting our patients. So there's never a bigger voice than the collection of voices that can be present in one document. And this survey gave us a screenshot of the limitations we have in our country, which wasn't just geographical, but it was also social, economical. So the initial evidence, as I said, you shocked even our rheumatologists. But this document for us became like a piece of liquid gold in the hands of our organization, because this was the first credible voice we ever had and our first opportunity to make South African-based statements. Why would it be so terrible to have axSpA? IMAS highlighted these issues very clearly and almost illuminated a pathway for us to plan our advocacy in South Africa. As you know, axSpA is the lesser known rock star, the one that sings only the cover tracks. But now for the first time, we had unique lyrics with a unique song that spoke South Africa. Most of our rheumatologists see patients in their practices, but few of them can really put together a global view, and collectively, we can make these changes for the axSpA patients. We've also been able to launch a court case against the government, which the IMAS data was pivotal in identifying these challenges and the patient burden. Next slide, please. Our rheumatologists are really stretched in South Africa. Most of our specialists work really, really long hours, and they volunteer in clinics, and a lot of them are very involved with training fellows. So, of course, this makes the opportunity for our rheumatologists to be out and about and attend the conferences and collect the latest data and statistics almost impossible. All of our rheumatologists treat all of the rheumatic diseases in South Africa, but we do not actually have one rheumatologist that specializes only in axSpA. Of course, this makes the field very general and not specific. So you can imagine what this data does for our rheumatologists. We literally give it to them in their hands in bite-sized portions, and this obviously can help them further any other research that they do. The sad reality for our rheumatologists in our country is that even they struggle to find funding to attend these big conferences and to access the data. So IMAS really fast-track the data, putting it in our hands, enable us to pass this on to our rheumatologists. Next slide, please. So I think IMAS really provided a platform for our association to make big statements and to target areas and needs and where the gaps are in education. I mean, we could clearly see that we had big problems. I mean, if you can imagine, it's like a big green swimming pool in front of us. Didn't really realize what the details of that was until we could see our specific data of South Africa. So we could see now we have a green swimming pool, and now we've realized that we can now come up with a solution to get this pool to look really blue again. So I think if it wasn't for the IMAS data, we wouldn't have been able to really see what the specific problems for IMAS was. And of course, this tool is a great educational tool for us. And it gave our team a lot more confidence to start working with data and learning how to ask answers. Teaching us how to find the answers if we ask the right questions. And then, of course, it also taught us how to use this data set to speak to various stakeholders and funders. Next slide. We've just finished our first ever manuscript about axSpA in South Africa. That was a massive celebration for us. Huge victory for our disease. And as many of our HCPs were very skeptically looking at the patient data, and Marco can tell you more about that. And the role of the patient voice, we actually now clinicians looking at this data and taking us seriously. We also use this data with our training programs with our HCPs and our physiotherapists. So the IMAS data really gave birth to very unique South African-based answers that we needed questions for. And it inspired us to roll out our own national patient research program. And this will now finally give us the answers to why our pool is green and how we're going to fix this problem. Thank you.
I have I have so many words and no words at the same time. Miranda, that's amazing. I love the idea that what you've done is you've taken the IMAS process effectively and supercharged your patient organization with that. You know, you basically said that we're setting up with a patient organization and we're going to use this data, we use this process to get the data, then to take us from zero to absolute heroes within the industry very rapidly indeed. I love that. And I think there are so many lessons in that for all the other patient organizations in the room, whether you're new or established, well established, to lean into this data set. Absolutely fabulous. Are there any questions that anybody would like to ask Miranda, or shall we move on to a discussion right now? I'm going to just quickly hold that thought a moment. Does anybody have any questions for Miranda? In which case, I think we should lean straight into discussion. Miranda, I think it was just superb. Thank you so much for that presentation. Thank you, Miranda. Thank you, Victoria. Thank you, Joe, for your presentations. I think that joined up way of thinking about of where the data, what the data says, how professionals are using the data and how they can lean into that data, and Miranda, how patient organizations using it too, is fabulous. And I love some of the questions and comments from the floor as well about the data sets, and I think all this has been so important as a conversation. I would love to talk about anything really relating to the IMAS report now, today's presentation as well, and the IMAS study more broadly. Joe, if you could, are you going to be able to note down some of these things that we talk about them now? I think Joe, brilliant. Joe's going to share a screen so we can, oh, look at that. Very organized, Joe, thank you. I'm not quite sure where to start, but I would love to ask an initial question of everyone in the room, which is, how could, oh, so Nadia's got a hand up already, and I'm almost going to ignore that hand for a second while I ask my first question. Unless, Nadia, you want to jump in. Do you want, is it too late? Or do you want to jump in now quickly? She's shaking her head.
I was like, because there is room for discussion, I'm IMAS, as you already mentioned, is a report that's so rich with so many things to discuss, like, and comment on. And I have to say that the mental health impact, because it's mirrored and depicted in every aspect of the IMAS report, even the socioeconomic and the access to health coverage, like every bit and piece of that report kind of like has an undercover mental health aspect of it, because like this is why I wanted to make my comment early on for others to maybe jump in after me. And because I was wondering when I first read the report like a few days ago, like how many people don't actually talk about that aspect of their burden of the disease, because the impact is huge, the research says, and the actual lived experience says, not my lived experience, like I've researched a little bit. And you know, the stigma of the whole situation, like living with the axSpA with chronic pain, the stigma is huge. And it's different, like if you live in Europe, it's different than if you live in Asia, like different, I mean, in the cultural aspect of the matter, because in Europe, the stigma is concerned, are concerned with their work environments, talking about the disease with their colleagues, with their extended like environments. How are they going to be conceived when they are absent, because we have the number of 20% being on a sick leave on the day of the filling out the survey, which is a big number if you think about that. Like it's a big number, 2 out of 10. And then the stigma for the Asian people is concerned that they prefer, like people in Asia prefer to have a physical limitation or disease rather than a mental health problem. So how much of that problem are they reporting? How much are they discussing about their sleep disturbances, their anxiety, their depressive symptoms? And being on that, how much are they discussing about their pain and the disruption of the pain in their daily lives? So I'm always wondering, how much do we know about the burden of the disease actually in all parts of the globe?
I think it's really interesting, Nadia. I think there's two parts to that I'd love to to really highlight. Is one is that you're talking about the cultural differences that affect the reporting of mental health. And I think that's fascinating. The other thing that I'd love to know is that once you recognize the mental health impact, what do you do about it? Exactly. And I know that some countries, the resources to deal with mental health are more scarce than other countries.
I mean, your country has many resources. Mine has a few. I'm from Greece. Like how many resources are there in Latin America or in the Philippines or in Panama? Like I'm wondering.
The good news is we've got people in the room, so we can actually ask this question. So I mean, if anybody would like to go off mute and just jump in and say for their country, you know, what do they see for resources here, but also maybe reflect on the cultural side of things. That would be amazing. Loris?
Yes, hi. Yes, I wanted to say that it's the same across all these different platforms. There's a stigma to go to mental healthcare provider if you feel bad, because it's a stigma, at least in my country. And the other thing is the underdiagnosed amount of patients with ASIS is really, really low. And when I get to learn more and I talk to patients, I wonder if they really have arthritis or ASPA. So, and there is it's a problem, and also regarding the amount of access to innovation and medication and therapy. The problem is that it's not continuous. We might have very good drugs, very good access, but then the government stop and put those resources in another highly prioritized activity, to say something nicer. So basically, yes, in my opinion, or gathering the information from our members, mental health is something that we tend not to accept, and also the burden of disability is very high. But I must say that we have a very good disability law in the country, meaning that I could be pensioned in a short term up to 60% of my salary if I am not able to work for 2 years or so, and it could extend. So there's a possibility for that. And in the law, it also has a lot of discounted benefits that goes anywhere from 15% to even 50% in things as, you know, foods and traveling or courses. So it will supplement that loss of income that you might have in purchasing your medication or paying for your physical therapist. I hope I could encompass some of the things you had in your mind when you asked the question.
No, it's amazing, Loris. This is really helpful. Thank you so much. And Prachi, I see you have your hand up too. It also looks like you've lost the unmute button.
Able to unmute. Hello. Yeah.
Yeah, you're good.
Yeah. Sorry, I was not able to unmute. Yeah.
Uh-oh. Is Prachi frozen for everyone else?
Hello.
Oh,
Yeah.
you're back again. Excellent.
Okay. Yeah, I said, as Nadia pointed out, there is a huge cultural difference, and yes, it is a taboo. In India, it is a huge taboo to have mental illness or to talk about it. And in fact, I would like to say a couple of points. At first, it is about the recognition of the illness. Because if you say that you're feeling this or that, people don't recognize it as a mental illness in the first place. They just kind of tell you to just go through it, and yeah, it happens with everybody. So there's no respect for those emotions. At the same time, even if the patient goes and talks to the doctor and saying that he feels this way, unfortunately, even the doctors, rheumatologists don't recognize it as a mental illness. And it's kind of a victim blaming thing where they expect you to just get along with your life and just, so to say, man up to the whole.
I think
they stop.
Oh, she's back again. Okay, you're back again.
Oh.
Okay. You vanished
So
for a
the
moment.
patient,
Yeah, you vanished for a moment. It's okay.
Yeah.
Keep going.
so the
It's typical timing, isn't it?
go
What I'm
for
going to
it
do
and
is,
say,
Prachi, I think you may have a little glitch on at the moment with your internet. It's kind of
Okay.
pausing and starting again. So what I'm going to do is hold your thought. If you can write
Okay.
down some more of it into the chat, that'd be amazing. What I'll do is I'll move to Brenda, who's also got a hand up, and then maybe we'll come back to you afterwards, if that's okay. Super, thank you. Brenda. And you're on mute, although it says you're not on mute. So I don't know what's going on there. No, it looks like there's nothing like technology sometimes. It's one of those irritating things. I want to just reflect that actually what's really interesting here is we're talking about the differences between different cultures and the scarcity of resources and things like that. Now, and Nadia pointed out how, you know, in the UK we've got it all covered. You know, we've got the resources and everything else. I just want to say that when I went for my insurance renewal, for my life insurance renewal, they asked me about my mental health side of things, and I disclosed that I had mental health help assistance, and my premium, my insurance premium, went up as a result. Yeah, it cost me more money because I needed help for my mental health and my life insurance. So I don't know what they're thinking I'm going to do. There we go. Dale, you've got your hand up.
Thanks, Raj. I think mental health is a key issue. In my mind, there are at least 3 issues. The first is, so rheumatologists often say they don't feel they have time within the consultation to cover mental health as well as physical health. But more importantly, they also say to me privately, they just don't know what to do if a person in front of them with axSpA has a mental health problem. They don't know what to do with them in terms of their professional ability to support that patient, but also whether they can refer that patient on to mental health support system within the broader, health systems that exist. So I think part of our challenge is figuring out really how we can support rheumatology teams, either to have psychologists embedded within rheumatology or appropriate access to them. But I think the third issue is the cultural one we just talked about. The cultural issues exist in my country too. When I go around the country visiting our NAS branches of volunteers who get together, it's often a badge of honor. They tell me, we don't talk about axial SPA in our sessions, particularly men. Well, why don't you? So I think part of the challenge for patient organizations is creating the conversations about mental health, actually. Otherwise, we're not going to change any of that.
Wonderful. And do you see, Dale, do you see this being something that IMAS can help with?
I do. I think we're barely beginning to lift the lid on mental health and axial SPA. People with axial SPA don't talk about it often themselves, particularly men. Our health services aren't equipped to support patients with their mental health. I think a deeper dive into that with some really good data to support policy at national level would be a really good thing to do. Yeah, absolutely.
Got it. Prachi, thank you very much for your comment there. I think this goes back to one of the other comments made earlier on about the way in which patient detail. I think you said about the patient taking ownership of the problem themselves a bit more. Was it detail? I think you said that. I may have mistaken that. But some, patients being more in control. And I think that, with the right data and with us talking about the right data and being empowered by IMAS, it enables those conversations to be able to say, look, it's not just me. People with axSpA experience this. And so it kind of frames the conversation a bit more for them. I am really aware that we are running short on time because we've had such great presentations, and it's always the case, isn't it, where you feel like you've got all the time in the world, and then suddenly the conversation starts and the presentation starts, and they're so interesting and you want to let them carry on. I'm aware they're running short on time. Has anybody got any more things they would like to discuss? I mean, I would love everyone to think about and maybe send in their thoughts afterwards if they have a moment to think about how could IMAS data be used to increase the understanding of axSpA and improve health outcomes in your own country. For me, that's a really big thing, is that you think about your own country. When you've looked at this data coming out, what would you like to see? How can that be framed in a way that helps you? Marco, you've got your hand up.
So thank you so much. So I think this is really the main goal that we were following when we started with Atlas first. So I think that this meeting itself represents one very important achievement. We are talking, first of all, we are at a global level. We are not at local level, we are not at regional level, we are not just in a patient community meeting, but we are involving other rheumatologists of a very, very knowledgeable rheumatologist, has Victoria or Dennis, who is not here, but is participating, and Fernando or Sofia, no? And now that, as we know, Victoria is even reaching, being the new president of ASAS, no? I think it's also very important for the patient community, no? I think that we have achieved, many goals, like to have a scientific voice, through the articles, through the Congress presentation or books, but also to influence the clinical practice, creating evidence of aspects like diagnostic delay or disease activity or the phenotype of axSpA. We have also been able with IMAS to inform and to educate patients, but also, and more important, to have policy incident. I remember when in Spain, there has been meetings at the Congress, Spanish Congress, the higher level of policy incidents, but also in other countries. For example, in the UK, I remember when Dale downloaded the Atlas report in English that was translated to English and used it as a tool for one of his meetings at the British Parliament. So I think that's a very important achievement, to have such a tool that helps us to create communication with the clinical community, with physicians, but also with policymakers, because Atlas, IMAS, or IMAS provide information that is useful for different purposes, for training, also for economic consideration, to highlight the work-related issues, for example, for how axSpA should be considered for recognition of disability or sick leave, and also for access to healthcare and to the best treatments, like in the case of South Africa, where patient has to pay out of pocket, because it's not considered as a priority within the government. So I think there are many things that we have achieved, but still there are many things we should still being able to reach using IMAS for this discussion and for this challenge in relation to axSpA patient community.
I love that you've said that, Marco, because I'm now going to turn to Mike and say, so Mike, what are the next steps?
Okay, the next steps. There are three things I want to focus on for a few minutes. First, there's a question we're often asked about whether we're going to carry out more data collection, so I just want to cover that one off. Secondly, a few specific points about the role of IMAS to drive change in policy and practice. And third, which has also already come up, the potential of IMAS in professional education. So first about data collection. This, as we know, is a very large sample size. It's over 5,500 people. It's the most comprehensive analysis that's ever been of the impact of axSpA on multiple aspects of people's lives. And we also know it is representative of the experience of people around the world with axSpA. The statistical analysis and the number of peer-reviewed journals and conference presentations for which IMAS has been accepted shows us that. At the same time, more data is always good. And some of the data was gathered 5 or more years ago, so it's not quite as fresh as treatments change. Now, we want IMAS to be an advocacy tool that creates change and is going to improve people's lives. And we're going to plan our advocacy that supports our members' work in their countries. And that's now about 45 countries and growing around the world. And we'll also be working with other international alliances like GMUSC and EULAR. Now that work might, and I expect it will, show where there are gaps in the data. And if we can fill those gaps, it could strengthen the case for change that we want to make to policymakers and the healthcare professionals. So that's where we're going to look to gather more data, where we can see a line of sight to how it will strengthen the case for change. And of course, that won't be crystal clear because advocacy and change is never straightforward, but we want to see where there's that line of sight. So that might be gathering more data in certain countries and certain regions or with certain demographic population groups. Now we're starting to talk with our members about how we can support them to use IMAS in their countries, the way that Miranda and some others have discussed. And that's going to be an important part of the agenda later this year for our council meeting in Colombia. So as many of you know, and I hope loads of you will be there, every 2 years ASIF brings together its members from across the world for a 3-day meeting. We're also going to start looking at taking regional approaches, where countries in geographic regions are used to working together on healthcare issues, or where they have similar healthcare systems or a history of sharing expertise and knowledge. We're going to begin this work again when we gather in Colombia, and we're going to have a meeting specifically for our Latin American members and stakeholders to discuss the challenges that they face in raising awareness of axSpA and supporting patients, especially in the context of Latin American cultures and health systems. And what we hope that will begin is a process of exploring how ASIF can work with our members and stakeholders in that region to respond to those challenges. And that's a model that we want to explore in other regions of the world as well. In the immediate future, we've submitted 5 abstracts for this year's EULAR conference. We're just waiting to hear back about them. And with our advisors, we're looking at developing a library of IMAS evidence that other clinicians and researchers can incorporate into their presentations or papers about axSpA. And we're also looking at what other analysis we can do with the current data, as well as opportunities for submitting to other conferences and other publications. The question of professional education came up earlier, and I just want to focus on that for a moment, because several of the calls to action focus on healthcare professional education. And while ASIF is not a medical organization, the data provides a really rich insight into the effects of axSpA. As Miranda highlighted earlier, the healthcare professionals really welcome that insight, and it's an insight that they miss when they're focusing especially on rheumatology. IMAS, of course, also highlights the need for awareness among other specialties who might see patients before diagnosis, and of course also for multidisciplinary care, the rheumatology, physiotherapy, mental health support, treatment of comorbidities. So we're starting to look at how we can contribute to greater awareness and knowledge among healthcare professionals. For example, adapting the IMAS data to forms that can be included in existing education programs for healthcare professionals, either before qualifying or, in my mind, very possibly, as Victoria said, after qualifying, when professionals have a little bit more time to focus and have more experience of patient care. So I hope that and the rest of today's webinar has been a useful insight for you. It really sounds like it has been, into how we and our members and our partners in the advocacy world and the pharmaceutical sector plan to turn this data into change that improves people's lives. Please do, like Raj said, continue the conversation, get in contact with us. It's a conversation we're certainly going to continue to discuss your reflections, your thoughts, your ideas. So thanks again for joining us today, and I'll hand back to you now, Raj.
I would say thank you so much, Mike, and thank you everyone for being here on this call. It's so important that we get the involvement of all our members and our kind of stakeholders who play such an, you all play such an important part in these conversations. Victoria, the big takeaway for me from today, I have to say, is the need for me to be more precise around the difference between manifestations and comorbidities. I really never really truly considered that actually so many things we talk about being comorbidities are actually not comorbidities, they're actually manifestations. And I really appreciate that clarification that you made. I love it. I'm going to definitely lean into that more often. I also think that, just reflecting as a whole thing, this community has come on so far over the last 8 years since we started, Atlas Project. I mean, Mark, I know it's been longer than that for you, but for instance, my involvement with the Atlas Project, it's come on so far, and there's so much further to go with this. And I'm loving the fact we've got these plans, and I love the fact that, despite the fact that, I love the fact that we are going to continue these things. So, Mike, thank you so much for taking the charge on this and going forward in this. Marco, thank you so much for your continuing involvement in these things, which I know we truly appreciate too. And thank you everyone for being present today. Absolutely brilliant. Have a wonderful day. And if you want to just go off mute and just say thank you or wave or any of those things you'd like to do at the end of these calls, please feel free.